In a recent clinical trial, a new B-cell killer outperformed Aubagio in relapse rate and some MRI metrics. It begs the question, should we still be using Aubagio in clinical practice? To hear my answer, don't turn away, because it starts right now. Howdy! Thanks for learning about MS with me, Aaron Boster. I started this YouTube channel to help my own MS clinic patients learn between visits, and it's my hope that through these videos, I can help you learn too. Today's topic, does Aubagio still have a role in treating MS in 2019? In a recently presented clinical trial, a new B-cell killer called ufatumumab was pitted head-to-head against Aubagio. In that trial, we found that UFA outperformed Aubagio with a better annualized relapse rate and better metrics on MRI, at least as it related to contrast enhancement and new T2. It begs the question, should we still be using Aubagio to treat MS in 2019? To answer that question, I think we need to review some facts about Aubagio. We need to consider how does it work, and what's the efficacy data for its ability to improve relapse rate, disability progression, MRI as it relates to contrast and T2, and brain volume loss. We need to consider its side effect profile and how tolerable it is. Basically, we need to make a list of the pros and cons, the strengths and the weaknesses. At the end of this video, I'll share my own personal impressions of if we should use Aubagio, and if so, where. Let's jump in. We'll start by considering Aubagio's mechanism of action. In other words, how does it work to help MS? It's kind of interesting. This is a once-daily pill, which makes white blood cells play the freeze game. This is not an immunosuppressant. It's called a cytostatic drug, and that it makes the white blood cells unable to rapidly reproduce. The white blood cells can still limp along, making a new cell, but at a slow pace. This is interesting because it slows down autoimmunity, but it still allows you to fight infections. The mechanism of action also may have some antiviral effects. Now, this is kind of interesting because some people believe that MS may be caused by, triggered by, or worsened by a virus, EBV. And so some people talk about its antiviral effects, although I think that's a little less understood. Now let's take a look at Aubagio's efficacy, specifically its ability to decrease clinical attacks or relapses. The way this is studied in a clinical trial is by looking at what we call the annualized relapse rate. You take a group of patients on drug A, and then a group of patients on drug B, and you look at, over the course of the trial, the average number of attacks each group had per year, or the annualized attack rate or annualized relapse rate. Today I'm going to be reviewing two clinical trials. The TEMSO trial, which was the original trial where we studied Aubagio back in the day, and then a more modern trial, Asclepios, where we compared Aubagio to the new drug, ufatumumab. So let's start with TEMSO. In the TEMSO trial, we compared Aubagio to placebo. So a group of patients with MS were either taking Aubagio or they were taking a fake pill, placebo. And at the end of the trial, what they found was patients taking Aubagio had 31% less attacks compared to placebo. And this was highly statistically significant. The annualized relapse rate was calculated to be 0.36, which is kind of a statistical way of saying, on average, those patients had an attack once every 2.7 years. Now, the TEMSO trial was done quite some time ago, and we actually have long-term follow-up data, where we've continued to follow as many patients as possible from the original trial. And we now go out 7.5 years, which is really powerful. So we now have a sense of how do patients who started Aubagio 7.5 years ago do now? And the number is really impressive. The annualized relapse rate quite low at 0.17. That's like saying they had one attack every 6 years. That's good stuff. Now we turn our attention to a second trial. This is the Asclepios trial, one that was recently done, where they compared Aubagio against a new B-cell killer called ufatumumab. Now, ufatumumab did much better than Aubagio in this trial, but I want to focus on the Aubagio data. The annualized relapse rate for the folks in Aubagio in this modern trial was better than the original trial TEMSO. The annualized relapse rate was 0.02, which is like saying they had one attack every 4.5 years. So what does this mean in summary? Aubagio certainly does a lot better than placebo, but it didn't do as well as this new B-cell killer. Also, Aubagio's annualized relapse rate over 7.5 years is really very nice. So let's keep this in mind as we look at some other outcome measures. Now we turn our attention to a different clinical measure, confirmed disability worsening, or CDW. Now, CDW has nothing to do with attacks. It's looking at the neurological exam. So if you have a neuro exam and you develop a new deficit, so you now have new difficulties doing something, maybe you're walking with a limp, or you can't feel your hand, or your other hand's clumsy, or you can't see as well, something like that. You have developed some worsening. And if we check back and do another exam 3 months or 6 months later, and you still have the same problem, we've confirmed the disability worsening. And so again, in a clinical trial, we can compare a group of patients with MS on drug A against a group of patients on drug B and ask who had more clinical worsening when we check back later. Again, I'm going to share data from the TEMSO trial where patients were compared on Aubagio or placebo, and then I'll talk about the newer Asclepios trial where patients were compared to the new B-cell killer ufatumumab against Aubagio. So let's take a look. In the original TEMSO trial, the 3-month confirmed disability worsening, meaning people developed deficits and they were still there 3 months later, we compared Aubagio to placebo. And the Aubagio folks had 30% less disability worsening compared to placebo. So they did better than being on a placebo, which is good. We also have long-term follow-up data for those patients. Like I said earlier, we can go out 7.5 years. And at 7.5 years, 61% of those Aubagio patients had no progression of their disability. They went 7.5 years and they didn't get worse on their exam, which is awesome sauce. In fact, on average, the percent change on the EDSS, the disability scale, was less than half a point. And so that bodes very well for Aubagio's ability to decrease disability. We now turn our attention to the modern trial, the Asclepios trial, where patients were either on Aubagio or the new B-cell killer, ufatumumab. The patients on Aubagio had a 15% 3-month disability progression, meaning at the end of the trial, 15% of the patients had developed disability which was still there 3 months later. If you look at a 6-month window, 12% of the Aubagio patients developed disability that was still there 6 months later. When you compare how the Aubagio patients did to the ufatumumab patients, the folks on ufatumumab did better, about 33% so. So in summary, Aubagio has pretty solid disability data. It does way better than placebo, but it didn't do as well as this new B-cell killer. And we want to keep these facts in mind as we consider the whole package. Let's move on. I'd like to talk about one more clinical measure before I move on to discuss MRI. And it's actually my favorite metric in MS, CDI, or Confirmed Disability Improvement. This is the opposite of CDW. It's saying that someone with MS improved their neuro exam. Their neuro exam literally got better. And when you check back 6 months later, it was still better. So that's awesome. Now, we don't have CDI data for Aubagio from the original TEMSO trial. Why? Because we didn't even have the measure back then. We didn't know about it. It's a new measure. But we do have it for the modern Asclepios trial. And so when you look at the Aubagio-treated patients, 8% of them improved their neuro exam, and 6 months later it was still better. So there was an 8% CDI. The ufatumumab group, the new B-cell killer, had an 11% CDI. And 8 versus 11 is not statistically significant. What this means is that the patients on the ufatumumab drug didn't do much better in improvements compared to Aubagio. That's interesting. Let's keep that in our minds as we now talk about MRI. The first MRI measure I'll talk about is contrast enhancement. So when you have the MRI and they give you the dye in your arm that makes you feel like you're going to pee your pants, what it does is it lights up new lesions. So if there's a brand new brain lesion, it'll light up. And we can study how many new GAD-enhancing lesions someone has at the end of a trial. In the TEMSO trial, we compared people on Aubagio against placebo. And what we found is people on Aubagio had less new enhancing lesions. Just to give you the numbers, on average, there was 1.26 new lesions in the Aubagio arm compared to 1.3 new contrast lesions in placebo. So clearly, Aubagio decreased new contrast-enhancing lesions as compared to placebo. But we don't treat patients with placebo. We treat them with drugs. And in the modern Asclepio trial, we compared Aubagio and ufatumumab, the new B-cell killer. Here, ufatumumab did way better in decreasing new contrast lesions compared to Aubagio. Just to give you the numbers, it was about 95% better. And so clearly, the B-cell killer did a much, much better job at decreasing new enhancing lesions compared to Aubagio. So let's talk about T2. When I say T2, I'm talking about the new white spots on the MRI. So when you get an MRI, and then you get one a year later, let's say, you're looking to see if there's any new white spots compared to the last time. And this is what we do in clinical trials. When we studied Aubagio in the Tower trial, this is one of the original trials for Aubagio, we found that we were able to decrease the amount of new T2 lesions by a lot. So Aubagio improved that by 69% over placebo. When you look at Aubagio against ufatumumab in the Asclepios trial, the ufatumumab B-cell killer did way better than Aubagio. So it was about 83% better than Aubagio. So Aubagio does a good job against placebo, but this B-cell killer did way better than Aubagio. And that's as it relates to making new T2 lesions. More information to keep in our heads. The last MRI metric I want to share is my favorite, or the one that I feel is maybe one of the most important, and it's looking at brain volume loss. Everyone over the age of 18, MS or not, has pre-programmed brain shrinkage. Just like your skin gets thinner as you age, your brain literally gets smaller as you age. Here's the thing. In untreated MS, it's way faster than normal, upwards of 10 times faster than normal. And so we want to look at MS drugs that can slow the rate of brain shrinkage. Now, Aubagio was studied in the TEMSO trial using a special software called Sienna. And what it showed is, as compared to taking placebo, we could decrease the brain volume loss on Aubagio by 37% in the first year and 31% in the second year. And that's really impressive. So Aubagio did a bang-up job of decreasing the rates of brain volume loss as compared to placebo. Now, in the modern Asclepios trial, we compared rates of brain volume loss for patients on Aubagio compared to patients on ufatumumab. And what they found was fascinating. The new B-cell killer, which did such a great job of decreasing new spots, was not able to outperform Aubagio. There was no difference statistically in either drug's ability to decrease brain volume loss. Very interesting. Considering the efficacy of a drug is only half the equation. To really understand the risk-benefit, we have to consider the efficacy and the safety tolerability. So let's talk about safety tolerability as it relates to Aubagio. From a tolerability standpoint, there's two things that come to mind. Aubagio can cause GI upset, and specifically loose stools or diarrhea. It doesn't do it with everyone, and if it does occur in my clinical experience, it'll only last for a couple months and then go away. I've only had a few patients where the GI problems were significant and they had to stop the medicine. Now, when you look at the clinical trials data at GI, it's like 11%, so not very high. But that is something that we have to consider. Also, when considering tolerability, about 13% of patients have transient hair thinning. So it's very interesting, actually. In 13% of patients, about 2 to 4 months into taking the drug, their hair will come out more in the comb. And this goes away at 6 months, whether or not they stop the drug. I can tell you, having used Aubagio in many, many patients, I've had one who had significant hair loss, where it really, really bothered her, and I understand why. And it did come back, but it took quite some time. So alopecia is something that we have to consider. When you think about the safety, the biggest issue that I find with safety is related to the liver enzymes. Aubagio is metabolized by the liver, and in the first 6 months on it, you have to check liver enzymes by a blood test once monthly for the first 6 months. If it spikes, then you can take the patient off the Aubagio and it goes back down. It's really not that big of a problem. But you have to check it so that you know if it does that. After the first 6 months, you only need to check it about once every 3 to 6 months, which is much more tolerable. Now, Aubagio is a medicine that we wouldn't like to get pregnant on. And so we have to be planful not to try to become pregnant, even by accident, while we're taking Aubagio. My favorite way to take care of this is by doing like a Depo-Provera shot or an IUD, where we're going to avoid pregnancy. If, God forbid, we became pregnant on Aubagio, there is a way to rapidly remove the drug from your body. By drinking a special liquid 3 times a day, we can get the Aubagio off your body in just 11 days. And so I like knowing that there's an out clause if we had to get it out of you. That's really the short and the long of the Aubagio side effects and tolerability. And I would say one of the absolute strong suits of this drug is the fact that it's really easy to take and it's very well tolerated, and the risk profile is pretty nice. Now notice, I didn't talk to you about crazy infections or cancer or any of these other scary words. And when you're considering the risk-benefit of Aubagio, I think the side effect profile is one of its strong suits. Okay, we just went through some efficacy data and some safety data. So let's make a list of the pros and the cons for Aubagio, and then we can decide if we think it still has a place in treating MS in 2019. As far as the cons for Aubagio, things that are not so good, it is not the strongest medicine at reducing relapses. It's also not the strongest medicine in decreasing new contrast-enhancing lesions or new bright spots on the MRI. Those are things that are weaknesses of this drug. It can do it, it's just not awesome at it. What about the pros? Well, it's a pill that you take once a day. And a once daily pill is something that most people can tolerate doing. It's not a shot, and it's not an infusion, and you don't have to take it multiple times. The second pro is that it's very well tolerated. Some people have GI upset that normally is not there or it goes away. Very rarely there's transient hair thinning. Again, that goes away. You have to check a couple blood tests, but after the first 6 months, you're doing that only once every 3 or 6 months, and most people tolerate that very well. And we don't see scary side effects with Aubagio, so we're not talking about scary words like PML or cancer and stuff like that. Also, strengths of Aubagio, in my opinion, are its ability to slow disability progression. I think it does a good job of that, and to slow brain volume loss. I think that Aubagio has very consistent data in its ability to do that. So there's my take on the pros and cons of Aubagio. With all this information together, now let's decide if it has a place in treating MS in the modern era. Now before I give you my answer, I want to comment on why I think Aubagio was used as a comparator drug for ufatumumab in the Asclepios trial, the one I've been talking about, and in another modern trial. So why are we choosing to compare drugs against Aubagio? I think it's because it's a once-a-day pill. And so it's very easy for patients to take, particularly if they're going to be taking another drug on top of it as a comparator. I think it has a really nice side effect profile, and so it's easy to blind the patient to the drug. These are strengths of Aubagio, and it allows for a very, very nice comparator. It's also not a shot. Back in the day, we would do trials against shots, like interferons or Copaxone, and we've moved past shots as a community. And so I think that Aubagio as a comparator makes a lot of sense in the modern era. Okay, I'm not going to hold you in suspense any longer. Now let's hear my answer for if Aubagio has a place in treatment in 2019. Should we use Aubagio to treat MS? And if so, where? My answer is yes. Aubagio does have a place to treat MS in 2019. Where? In my opinion, it's in the second half of the disease. My opinion is that I want to hit MS really, really hard up front. I want to use the most effective medicine that you're comfortable with as early as possible. And so for me in my clinical practice, I like to use the monoclonal antibodies, Lemtrada, Ocrevus, Tysabri up front, because I think that they're the most oomphy. But we have to constantly reconsider the risk-benefit, and the risk-benefit for a given human changes as we move in time, as they age, as they pick up more comorbid conditions. And we might, in some cases, not want to use big, heavy-hitting medicines in people in their late 50s, 60s, 70s, etc. These people still have MS, and I still want to treat them. And I want to use a medicine that still provides some control, but I want the side effect profile to be better than some of those big, heavy-hitting medicines. When I think about the second half of the disease of MS, we don't have very frequent attacks. We don't have very frequent new contrast-enhancing lesions, but we do have brain volume loss, and we do have progression of disability. This is where I think Aubagio fits beautifully. As many of you know, I'm a proponent of the de-escalation model in MS. And so I'll throw a link up above where I've done some videos on de-escalation. And one of my favorite drugs to de-escalate to in the second half of the disease is Aubagio. If you'd like to learn more about MS drugs, click this playlist right here. YouTube thinks that you would adore this video right there. And if you haven't yet subscribed to my channel, please consider doing so by clicking the circle with my face in it. Go ahead and click my face. My name's Boster, and thank you for learning about MS with me. Until my next video or my next live stream, take care.